varicose veins. Varicose veins is a very important topic, both for treating the patient and also as an examination topic. If there are varicose veins in the world, you can be certain that you get and you should know how to approach it. So, vaibhav is our consultant vascular surgeon. Kindly agree to moderate this session. So, Nikitha, over to you. Thank you very much.
Good morning, everyone. I'm Dr. Nikitha, and today's class is about varicose veins, moderated by Dr. Vaibhav, sir. So, we will be discussing about anatomy of the mainly lower limb veins, in which varicose veins are most predominant, and the pathophysiology of varicose veins, the basic definition and classification, assessment, and treatment. So, anatomy of lower limb veins can be divided into superficial veins, deep veins, and perforating veins. Superficial veins mainly consist of great saphenous vein and small saphenous vein, and sometimes an accessory great saphenous vein. Deep veins consist of deep femoral vein, popliteal vein, gastrocnemius, soleus, anterior tibial, and posterior tibial veins. Perforating veins are divided into 4 categories on a broader basis, which are Cockett's perforator, Boyd's, Dodds, and Hunter's. It can be memorized in the form of C, B, D, and H. This is a visual representation of how the perforators are there in the connected from superficial vein to the deep veins, transversing the fascia. So the normal physiology of lower limb venous system is because of the gravity, it needs an extra mechanism to pump the blood back to the heart, and it is maintained by the walls present in the lower limb veins and the cough pump between the muscles and the difference in the capillary pressures. So normally the blood pressure, venous blood pressure in the lower limbs is 90 mmHg, whereas in the brain it is 10 mmHg. So the causes of varicose veins are genetic predisposition, prolonged standing, unbalanced diet, tight clothing, and uncomfortable shoes, large exercise and hormonal imbalance, obesity, and pregnancy. This is on a broader perspective, but if we classify it into primary and secondary. In primary cases, it is a congenital weakness of wall and absence of valves or incompetence, and presence of some genetic abnormalities like FOXC2 gene and lysosomal enzyme defects. Secondary causes are obstruction to the flow, as seen in the case of pregnancy or any mass present in the abdomen or ascites. And in the case of deep vein thrombosis, it can be as an obstructive or a destructive way of presentation. And in the case of AV fistulas, due to high pressure flow. So pathophysiology involves all the causes I have mentioned previously. So the genetic and hemodynamic factors and also the lifestyle and environmental factors of the patient together affect the cellular hyperplasia and apoptotic dysregulation. So what happens is the venous wall, which is already thin in general compared to the arterial wall, the damage of the venous wall occurs, which results in the dilation of the venous wall. The main important pathological agent here is matrix metalloproteases. So the imbalance of matrix metalloproteases results in the damage of the wall and vascular smooth muscle apoptosis and extracellular matrix degradation. This causes reflux of the blood into the lower limb veins. So this reflux results in the formation of varicose veins, which is defined as dilated, elongated, tortuous, and palpable superficial vein as a result of venous hypertension. There is a permanent loss of valvular mechanism. So patient presents with the symptoms of either itching around some visible veins, or burning sensation in the vein, in the leg, or muscle cramping, discoloration of the vein, as we see bluish or greenish presentation, and swelling in the lower legs in the form of edema, or throbbing kind of pain, or heaviness. So if we do not if the patient do not consider the symptoms, and if we just go ahead, he might land up in the complications and present with the complications like hemorrhage.
What is venous cord? I think it's what it is. After what is what is venous cord? Anybody? During this, they have what are the qualifications you know? There is arterial, there is venous, there is one more. Very basic. No. You have so you have to check among the they all have something to do with pain and walking. Arterial, after walking, you will get the pain. Venous, during the rest of the other thing. Nervous is continuously. Some right? You should all go like because there no mind. Both read of that has to be very clear. What is the amount of blood that is there in the invasive service in the gastric various and go in the blood. About 40%. So you write the volume from you call it the second heart, second pump. Second point that is so much blood in both part of the body. Number of volume, including that is a different side, that is certainly produce some good news. Second, I will reduce the reduce or reduce comma where people are soon because you put pressure on the borders. That forms your back in the storing temporarily. Let alone keeping the visual eye on this something
As there is pooling.
Usually, whatever questions. I have time of not. No, really. So what we do is generally, for example, now finish the so we can interrupt there and ask because anyway basically most of our questions are actually during the because at any phase, interruptions are very just to give you a background first. Sorry, 2 point. One, we have made a mistake about that. Second, at one phase, from anatomy, they do something else. And then the main purpose is that A, if they reach and there is no other part, they won't go. And we learn a little bit more than what please feel free to go on. Any questions? In between, I wanted to define or want to put pressure on the perforating things. You mentioned about the valves. Are those valves present in the perforated sources? Right. Other perforators, do they have that? Or?
Basically, I think there are no walls in the perforator, sir, but because of the pressure inside the pressure gradient, it moves from superficial to deep.
It's not necessarily that you have valves. But I want to tell this perforator is not the one which will define so that flow from superficial
too deep. Perforated do play a very important role, but I think that pressure gradient is very important. It is responsible for the flow of the vein and valves will just maintain that. But because of the calf pump, the negative pressure will develop, and that will suck the blood from the superficial towards the deep, because muscles want the blood. And that's how the mechanism runs. And when the valves get disrupted by some of the reason, we will not, that blood will not go in a unidirectional way. It will grow, but not all the blood will go. It's say 70% will go. 30% blood will just collect, keep on collecting in the vein and surrounding muscles and surrounding leg. And that's how the back pressure will come as responsible for venous hypertension, responsible for this. It's the main mechanism of the formation of the blood.
Okay. So the complications are as the varicose veins are pooled with blood, and the patient is itching. He might land up with a hemorrhage or eczema and dermatitis, periosteitis, and deep venous thrombosis because of incompetent walls and inflammatory changes, thrombophlebitis, ankylosis of ankle joint, talipes equinovarus, and calcification may also be present. So when the patient comes to the OPD with the symptoms and claim.
Very alarming because patients need a lot of blood outside the bed, just around the bed, and they get very alarmed. So calm them down first. Anyway, they can put better the more the time start. Are you talking about the pathophysiology of all those changes that right? How does that
Yes, sir, like briefly, sir, like 2 points. In classification, while mentioning the features. Yes. So when the patient presents with the clinical features, we'll classify the patient based on CEAP classification, which includes seven clinical categories in C, and E defines etiology, A means anatomy, and P means pathophysiology. So in clinical categories, there are seven stages, which shows C0, no visible or palpable signs of venous disease, but the patient has some complaint. And C1 is telangiectasias or reticular veins. As you can see, very minute veins, which are less than 1 mm. C2 is varicose veins. These are greater than 3 mm. We can call them as varicose veins. And C3 is edema. In this, there is a sign of champagne bottle. There is edema of the leg.
The swelling of the lower limb. That is one of the important causes can be in hypertension that can cause stability. You will not be able to visualize the varicosity actually, but there are the sufficient symptoms for the patient that she is landing into the OPD. Basically, number one is the swelling, and second is the calf pain, tenderness, discomfort. This is the most common symptom that patients will present with. Not necessarily patients will come with the champagne bottle of it might happen after 15 minutes. So most important is just the negative. Next level.
So C4 is changes in the skin color. Okay, hyperpigmentation. This is due to deposition of hemosiderin. The lipodermatosclerosis occurs. This is C4B, and over the discolored area. C5 is healed venous ulcer, whereas is the common complication of varicose vein. It could be either symptomatic or asymptomatic. So, etiological classification, as I have mentioned earlier, it could be either primary or secondary, and primary with the congenital presentation, and there could be no venous cause identified, which can be classified as EN. Anatomical classification based on which veins are involved, could be either superficial veins or perforating veins or deep veins, and there could be no venous location identified, classified as AN. The pathophysiology, it is classified in 4 categories: either reflux due to valvular incompetence, or obstruction due to the presence of abdominal mass or deep vein thrombosis, or it could be both, or no pathophysiology identifiable. I want. So, due to pooling of the blood, the migration.
Venous back pressure will be capillary dilation, later the capillary rupture will happen, and these RBC enters rupture and hemosydrin RBC is released from the capillary. They break down and they break down and then leave the hemosydrin, which causes an inflammatory reaction. That's what causes itching also. In addition to the inflammation and itching that you have, one of the reasons for both ulceration and bleeding is scratching, even at the skin. So each scratching, so they add to the recovery. The sequence is something that is very important.
So, I would like one of you to classify this. Patient comes with a swelling and tightness of the leg. On physical examination, there are varicose veins, lipodermatosclerosis, and healed ulceration. And scan shows great saphenous vein reflux and popliteal anterior tibial reflux. Signs of post-thrombotic obstruction of negative. So, what is the classification which we make out here?
There is already LDS and venous ulcer. C5, yes.
Symptomatic or asymptomatic, it depends on this. Yes. So the main point I wanted to signify here is that it is not a stage. It's not like if the patient is in C5, that we should not mention C2. If the patient has C2 and C3 features, we have to mention both of them. So it comes something like this: C234, D5S, EP, ASD, and PR. So it's not like a stage, it's like a component of the classification. So, as here we have mentioned, it's a refluxer. So the pathophysiology are reflux, that's it, sir.
You have to mention everything.
Yes, sir. It's in the published paper. They have told that we have to mention all the components. So we will have a clear idea of the complete.
C5 is because of the previous thing.
What does it?
Are you saying that you not on stage, but you must describe
Everything that is there.
different agent, different stage?
Not like breast cancer.
So,
There is one report that is part of the same. That's my learning. Yeah, I thought you mentioned the biggest worst case.
So the point is, if he has a varicose veins and lipodermatosclerosis, it will be different, and only lipodermatosclerosis will be different.
since you have mentioned that there is a discussion for that popliteal and antilateral reflux is also seen. So we know that for the varicosities, we have treatment. What is the treatment for the treatment?
I wanted to ask the last question, the same thing, sir. What is deep veins?
You just think about it. You didn't want to treat it.
But there won't be any
Already there is multi-valve. Can you do something about it?
wall replacement.
How many replacement? What do you do? What do you do? I heard standing. No, standing. Standing, how it is. It's same as, you know, actually, we are listening the existing working valve, listening was. In the reconstruct lab, the situation. What do you do?
We can answer that, but I don't know how effective it will be, and only the people does that. That is also a question. And after reconstructing the valve, there is not guidelines or no papers also that after reconstructing the patient has improved. Might have improved, but we don't know how much significantly improvement the treatment have after reconstruction. It's
These described, but not very popular, perhaps because of its limited size.
Yes. So after classification, we'll go for the clinical assessment of the patient. So the tests which generally advised are Trendelenburg's, Morrison-Koff, Trendelenburg's 2, Tourniquet, Pratt's, Fagans, Perthes, modified Perthes, Hoffman and Morse. I will show the different pictures. I want one of them to identify each test. So
First test. Confirm it. First test. Clinical exam, you have to do one test.
sir, I would go with Trendelenburg, sir, 1 and 2, which shows all.
First rule out DV. Always they say, first rule out DV. One test is there. Why should we rule out?
This
I will say the patient has thought of hypoglycemia. But you want to rule out why is it?
Sir, if the deep vein system is affected, so there is no need of doing the supervision once again. So you should not do it. You manipulate. Okay, embolism.
No. We are looking at chronic disease. Chronic, not acute. But please understand that the varicosities, they are only on the same blood back to the heart, but the deep vein is slow. You should knock that off also, technically. For that. So that's why logical thing make us do not do. So for this,
yes,
just
Perthes.
completely unimportant, but a piece of information. Just review a letter to the editor from idea. What happens? I'm a reviewer for them. The letter, newspaper, everything comes with people for review. And that particular, this particular person, letter makes a very valid point that treatment of varicose vein has gone beyond these tests. And that while not unimportant, do not place stress on these limited tests. Because we know that we now need to use some good vision. Okay. But for the exams, we need to know.
So what is the first test which is being demonstrated here?
Answer. If they don't know the answer, you
So there is venous marcation, and after that, in supine position, after lifting the leg, is trying to palpate the defects in the fascia, deep fascia for the perforator incompetence. So this is Fagans test. And this is Hoffman's test. Hoffman's test. This is for
Just mentioned to be condemned.
yes. So dorsiflexion of the foot is done. If the patient complains of pain, then in the cough region. In the
What is modified for this?
To tie this tourniquet and ask the patient to walk. Patient complains of pain. And we can also visualize the varicose veins around in the DVTs. For this, we show a small,
How long is the, how long is the water? 10 seconds, 30 seconds?
5 minutes.
5 minutes? 1 minute?
5 minutes.
I thought it was 5.
5 minutes, sir.
Need to walk a good length of time. What is this?
we are giving
What is the tone K do?
superficial veins will be blocked.
So these
The
veins
flow
will
should
not
be
be blocked. So
the deep the flow should be from the DVT.
if deep veins are patient, it will go up.
Yes,
If they are not patient, the block will be
pain.
more prominent of that things that are pain. So you don't in the woman's sign. What was the exception? You want to modify it, just calculate the top levels and place tenderness and indicates possibility of. Again, as Sir said, clinical tests have to be now confirmed with human doctor. The doctor will tell you over very quickly.
So is Brody Tendenberg and Tendenberg both same, sir?
Brody Tendenberg is Tendenberg 1.
Okay, sir. So this Brody Tendenberg 1 and 2. This is tourniquet test.
What is Tendenberg 1 and 2? What is it? I don't know.
Sir,
No, I mean, when I went for the exam, nobody asked me for a test. I think the tests are, as Sir told, for you people it is important because, but for the treatment purpose and all, because we will go beyond the test, we will go for the treatment. So always they have to work with the doctor.
See the examiner's mindset is changing, but we've seen some of the one-time examiners. See for you to understand the clinical principles is good, but anyway, clinical principles will only lead you to investigate the case in the right way. It is not, and you can't treat anybody based on the clinical case. But I don't think that two of these things you must know, even that, which I don't even say. One of them is this pendulum. Progress is the first. What we do that. Pendulum word is the first. Explain how we do it.
sir, with patient in supine position and leg raised up, we milk back the blood in the veins.
Empty the vein, empty the.
And then we tie a tourniquet in the groin region, sir, blocking the saphenofemoral junction that level. And we ask the patient to stand. And if the varicose veins get filled up, it means it's from the it's not the incompetence of saphenofemoral junction, but from the perforator incompetence. And when we but if it does, it is single positive, sir, for now, test 1. And if we release that, and if the varicose veins flare up more, it is also the saphenofemoral incompetence 2.
Renal work is one is we will remove the tourniquet. In renal work 2, we won't remove the tourniquet. So SL junction will block in renal work 2. So only the superficial varicose veins will see in renal work 2. In 1, we will see the excess competence.
Anyway, I really do this so I can't teach what is. Read up and be ready for the exam. Any educators, what are the things?
Like, in supine position, looking down the vein, try to turn
Tell us one first.
the one only. Or that, make the vein and then tie the tourniquet, ask the patient to stand and release the tourniquet. So if it starts filling from up, which means SFJ is involved. Second test is they don't release the tourniquet. So it starts filling from down, which means the perforator is involved. And second is the tourniquet as well.
Sir, after performing this test, we'll get an idea whether the perforators are blocked or not. I mean, incompetent or not. So in that case, we need to know which level of perforators are incompetent. For that, we perform tourniquet test, multiple tourniquet test, and will release from below so as to know the incompetence level.
So this much if you know what is 1 and 2. So 1 you won't release the tourniquet. Or 1 you release the tourniquet, second one you don't. So you will show whether there is perforator in addition to SF. And then multiple tourniquets, release it from below upwards to show the level of perforator.
I think the test wise, it's correct on but regarding the treatment wise, I can ask a few questions. If the tender of one SFJ is incompetence, then you are going to treat the patient. Or if SFJ is competent and only perforated, I am still going to treat them.
Then it depends on what are the other complications. No answer, no natural.
Question is talking to me.
Still compared to the same. Still anything more.
So that is part of treatment. So as in case, we are going to treat the patient. And there is a perforator incompetence, because we don't want him to get lined up in the complication. Okay. And out of the perforators at levels of the Viloni and which perforator incompetence is the most dangerous? Or which above and
Why, sir?
because that's land up in the gators area. It's the most venous hypertension will be maximum the angle, both in and the angle perforators are not working well. Obviously, the patient will be symptomatic very fast.
This post-medial and
Those are also the important things. The only when the patient is symptomatic because of that, if say you have to see if the SFJ is not competent, and most of the time patients will come with the varicosities in the thigh, medially or the lateral, and we have to attend that because ultimately it will land up in the venous symptomatic. So now what's happening is we are not looking with the SFJ only or SPJ only. We are looking all the perforators and as sir mentioned the anteromedial and lateral veins, the branches of the tributaries of the veins, and also the posterior tibial veins. We have superficial vein, tributary of the now we don't. We have to report that because maximum of the perforators will go and add that once the veins will be connected to the posterior vein. So we have to see all the perforators individually, and it's not defined that only SFJ or SPJ is incompetent. That means we need to treat the no. Other than that, also that's why we are doing all the tests. Perforators are also incompetent. It's ultimately for which the patient will land up to the and it's important. We have to treat him.
that's why what we remember is that the radiation in anatomy is maximum in venous. Most of the time, all other anatomy arteries, for example, nerves, they have anatomy every fixed constant. Whereas the venous system across body and very variable. That's why you need to tailor the treatment to the patient. That's why venous water is a huge knowledge.
Yes. This is Prats and Perthis. And this is Moose sign. This is also for DVT. Moose, Moose sign. Moses. Okay, sir.
How do we do that?
Sir, patient in prone position and with the ankle flexed, we compress the calf muscle, sir. And if he complains of pain, so sir, he has a tick. Yes. So we perform investigations after clinical assessment in order to confirm the insufficiency, the venous insufficiency, and to find out the source and to plan the treatment accordingly. So non-invasive investigation modalities are the Doppler scan and Doppler scanning, which has the significant Mickey Mouse sign, which is seen in the femoral vein, great saphenous vein, and common femoral artery. And Egyptian eye, in the case of saphenous vein, in between the fascia. The plethysmography is like air compression. Saphenofemoral incompetence, sir. Junction.
That's how we will identify that.
That's the normal. Once the abnormality comes, we will be able to identify.
And with this, you are not able to analyze whether it is competence or incompetence. This is the B mode. There is one more color mode will be there. In that, we will ask the patient to yes, that's an. So in that,
The plethysmography, CT venography, and MR venography for the clear understanding of the venous wall incompetence. And invasive techniques are phlebography and ambulatory venous pressure. This is the gold standard for the varicose veins assessment, in which a catheter is passed into the dorsal vein, and the venous pressure is monitored when with the patient walking, and also in other ways, as this is a plethysmography, air plethysmography, and intravascular ultrasound. This is phlebography, and few other tests for DVT are isotope studies of iodine 125 fibrinogen, isotope 125 fibrinogen, and varicography, specifically injecting the dye into the varicose veins.
Catheter and all, you will insert in that also. What is that? What is the stimulus? After that, what we have to see?
Patient while standing, it's a venous pressure, sir, and while after walking for a few minutes, and arm foot pressure difference.
You go in the standing position, the dorsal vein, how much of the pressure?
So in a normal person in standing, it is 90 mmHg, sir. Sir. That I'm not sure, sir.
I think ambulatory venous pressure is for taking care, if I'm not wrong, for the DVT also.
That you have to go to say. Yeah. Let me first say a principle. When you are presenting like this, the idea is going to understand why these things are happening. Okay. And it's good to know the theory of what are all called disintegrating, everything. But you must know what is clinically done on a day-to-day basis. What is the aim of any teaching? You want you to be good surgeon, safe surgeon. So you're not looking at disintegrating and see the mention those which are done, but stress on those. Mention those which are theoretically positive, but stress on those which are done. When it is done, you must know the principle behind it, how it is done, and what is its sensitivity and specificity. Your slides, your mind must have for everything that you do in practice. So this ambulatory pressure is just a measure of venous hypertension. Okay, so in a person with latent deep veins, there is a given pressure when the patient is standing. And when you make him walk and measure, that pressure will come down. Yes. Because the heart pumps effectively, the pumps will go up. Whereas in a person with DVT, this pressure will go up. That's all we need. Of course, as soon as we have to remember it normal and normal. Very good. Can you please tell us what are somebody comes with that? What are the investigations you do? Venous problem is probably the most important thing in a problem.
Let's say, depends upon in which state the patient comes. The patient is walking towards doing the OPD first time, saying that I'm having a dilated veins or whatever symptoms. The first thing that obviously will look clinically first, whether there is an obvious varicosity or not. If obvious varicosity, then you have to explain to the patient, and after that, the Doppler. In the Doppler, we are seeing
Talking about depth, what is it that you, what information do you seek in a dog? That's what you're going to say, right? That's thing, that's go on, exam,
venous Doppler. What are the things you will look for or you will ask from the radiologist that these things I want first to.
I mean, the perforators are examining.
Results are arguing for actual diagnostic, they explain the which system is involved. They exactly sort of what is
Perforators.
appropriate.
Perforators are marking of the perforator.
More important than that, is the clinically good what is first. So what are the signs on the Doppler which tells you that there is, what are the things you look for? You look for the, so I was mentioned about the be more where you just see an aspect. So how do they determine the flow?
So there is a reflex will be there. So not usually blue colors. When there is a reflex, there is a red color. Which will then
Still not so it measure the direction. The new quantify the.
I have 4 grades of dysphagia. Depending upon the seconds or how once a person is doing the pop or animal. If it is less than 1 second, 1 to 2 seconds, up to 3 seconds, 4 seconds, or more than 4 seconds. Depending on that, the grades will come. But yes, those are just the grades. You will be able to quantify as I told that how bad varicose surgery is going to happen. Or right now, patient is not having any ulcer. Problem will be like he will be more, sensitive to go ahead and have a ulcer in future. So that is something. And for perforators also it is quantifying perforator in contact. Right, superficial vein and deep vein, perforator. These are the things we have to.
What is the sensitivity, specificity of the human body? See the other thing, habits. Look at the sensitivity of the flow and conserva and deep breath is what happens to the flow, and then abdominal compression and see so all of these is telling whether there is any. I don't remember the exact figure, but it's very. It essentially means you can depend on the venous Doppler for a good song. We have to operate for everything. Or less than 2 seconds.
Definition of offering a patient any surgery or any treatment is when the patient is having incontinence. Even if it is for the 1 second and the patient is symptomatic with that, we have to offer and we have to treat the patient.
So then how does the grade work?
They works in, as I told, that let's say if it is more than 4 seconds, then the patient is more likely to have the symptoms, progressive symptoms, much earlier. Let's say if it is just for the 1 second and the valve is closing, back. That means valve is working, but it's not that much effective. But if it is grade 4, that means it's valve not at all working, and all the blood, like most of the blood is going down, then the patient will definitely be symptomatic or going to have a worsen very fast and the person will be having the grade of 1 or 2.
So I think venous Doppler is the only investigation.
We do the venous Doppler, and that will be that is the sufficient investigation for planning the patient. The only when the patient will come with the ulcer and let's say swelling, and if that also varicosities is there, then we are going to treat it. But let's say if the ulcer is not healing with that, then we have to go ahead with the MR angiogram to find out any iliac veins, basically to find out any obstruction in the iliac vein. That after treating the patient also why they are not getting the success in treating the wound or in the swelling of the leg, why it is not coming down. Then only we will go ahead with the next stage. But for the varicosities, I think doctor is more than.
Yes. So after the investigations, we'll go for the management of varicose veins, and conservative management includes compression therapy, in which we advise compression stockings, and this could be multi-layer. Right now, 4-layered compression stockings are advised in some cases, and limb elevation and exercises, walking exercise. In pharmacological treatment, we advise venotonic drugs. Most commonly I have seen in our setup is Daflon 500, and if you go for a surgical intervention, so there are a few studies, sir, but it shows that the tonicity of the venous wall increases relatively, and also the permeability. Nice.
First, I haven't done a recent work, study on it, but I've read some time ago. No evidence that these recent papers say that this is where your presentation of givers, you must go beyond textbooks. So people say this, when you do a subject seminar, you must go beyond textbooks. Textbook will give you a table. It does not help you in the clinical evidence based decision. So the second thing, the first one, security review. Yes, that's one. Second one, what is the effectivity, clinical effectivity of that one or any?
Yes.
The compression therapy you have mentioned, I mean, it's very vague. You think that for how long the compression is given, what are the grade of the compression, and which compression needs to be given, whether it is a 4-layer compression or 20-layer bandaging required for the varicosity. 20-layer bandaging, if you have mentioned that word, then you should know that where multi-layer bandaging is important.
Last one is the least.
Yes, and last one depends upon the again the pressure which is the pressure the bandage or stocking on the length. It is like up to 15 mm, 15 to 18 mm, from 80 to 20, 20 to 30, and 30 to 40 and 40 above, like that. Up to 4 grades are there. So head stocking, what sir is saying is the classroom which we will give for the normal patient, those who are long-standing, let's say bedridden, and we don't want them to have a infrequent condition for them, let's say 18 to 20 mm. From 20 to 40, or let's say basically from 25 to 32 mm, it means the class 2, where we will require the proper compression for varicose vein. So that patient is required to completely collapse. Even the means even the smaller veins like the reticular veins and the bigger veins and perforating muscle superficial, they will completely collapse in that patient. We will increase the pressure in terms of ulcers, then the patient will come up with the ulcer. That's when multi-layer bandaging will work, because beyond that, let's say that bandaging will be there for 24 hours, number one, and second, the patient will come back. That's when we go ahead to multi-layer bandaging for those kind of things. And grade for beyond 40 mm for which patient?
Sir, in these cases, if we use the compression bandage, I would just stopping the process. I mean, like, does the patient go back to normal, sir? Or are we curing or we just blocking the further mechanism, symptomatic?
So it has to be for life. So is there any brand as such?
For every specifications are there. You have to write it.
Level is problem.
Yeah.
Plus,
Class.
Above me or below me problem.
If there, how do you actually advise them to wear this problems? Wear it throughout the day or to have they?
Standard from morning 8 o'clock to night 8 o'clock. Whenever the patient or any person is sitting or standing, he has to wear it. Let's say some patient is having a night job, so he has to wear at night. There's nothing to do with the duration. It has to do whether the patient is sitting or standing. That time we need his leg supporting the in the sleep time. There's no need.
Sclerotherapy by sodium tetrahydrosul sulfate and other compounds. Surgical intervention, it's either by surgical stripping, which is a normal procedure, normally done procedure, or endovenous procedures, which use radio frequency or infrared laser or thermal or other chemicals to seal the or ablate the venous varicose vein. Yes,
Yes.
So, we should talk about that. So, one paper which you have.
just briefly, sir, like all the things in the components in the table separated them, sir, again, but not in a detailed fashion.
Postgraduate. I was saying we have learned quite a bit about the complex topics like that, or sclerotherapy, which is the preferred compound sclerotherapy. What is plain sclerotherapy versus foam sclerotherapy? What is the maximum potency dose? How do you do it? What is the post-op care? Every single thing is made. And similarly, the normal, what is stripping, what's the difference between various not strip? What are the, how do you choose these patients? Stripping better, multiple aversions of better. What are the newer things like lasers, radio frequency? What are the outcomes? Full words, aspects.
Yes, sir.
I think we should have it.
Yes, sir.
Yes, we discuss it with vaibhav, because they will be doing it on a regular basis. So we should comment as a subset or the methodology. First, I think, for example, there is varicose veins, the examiner will be bored. He will ask you, how do you do stereotype? You should know what.
Okay, sir.
Was this rated by vaibhav or did I because it was time?
Yeah, since he has
Best.
sent me.
So next time I think.
Make one more class, sir. Yes, sir.
If we learn that, all of this. I think we should have videos of how they do with laser or they do radio frequency.
Yes, sir.
2-minute videos of both. And then the pros and cons of each, long-term results. From papers, not just.
Yes, sir.
Tables. There is one paper which I the same, that study of extreme others. So you have all of that.
Yes, sir.
Good, so far, so good. I think
Finally, we asked for comments, questions, and on the subject and the assessment of the.
that's also a part of it. So what do you do? Students, how do you think it works?
But the rules, she has to do. She has to practice.
You know what?
Close.
Flow. Your comments?
Presentation of the focus more on the better results.
I think presentation was very recent. But only thing I want to tell you that that's how we have learned that whatever you write on the slide, and if it is projected to everybody, we should be able to answer that because you are liable to that word or that sentence. So let us say if you are written ambiguously in this pressure, you should think twice whether I should write it or not, because if you are not prepared for that, it's very difficult to go outside. We are the department, but if outside person is sitting and you are not able to answer it properly, then it becomes presentation. It doesn't carry a good sign. So remember always, remember whatever, and for you also, if you are presenting, presenting, whatever words, if you are writing that, you should be able, you should be answering to those words or those sentiments. Otherwise, you should think right.
Very, that is why keep on telling you. Not just about putting something there, you are able to explain why you are. Lot of things you are doing right. But you didn't know why you are stuck there. That is what you do back.
You should develop that. It will not come at once. But it's over the period of 2 years.
So, yeah, good presentation, but I will check. I check in whatever you said. What sir said about practicing before you present here, I think that applies to you.
That applies to everybody. Actually, that gives a lot of confidence.
You are very intelligent, and there is no doubt about it. Presentation is a skill, and most of it can be acquired. Then you just practice. All right. Thank you. Thank you.
Thank you.
Just comment to the chair. I will want to. I just want to develop it.